Everyone, my name is Jason Yee from the Indiana Spine Group. It's a privilege and pleasure to be here. We're going to talk about the history of cervical arthroplasty. My disclosure. In this presentation, we will explore the historical evolution of cervical disc arthroplasty. This timeline is best viewed within the context of available knowledge at the time. The issues back then motivated iterative design changes that led to where we are today. We will be concentrating on the US market, although some of the pioneering work was done elsewhere in the world. Prior to 1958, cervical radiculopathy was almost exclusively treated non-operatively. Surgical treatment by posterior laminectomy was known, but avoided in all but the worst cases. The main concern was the difficulty of accessing anterior pathology from a posterior approach. They also did recognize the wound healing issues related to the posterior approach. In 1958, Dr. Smith and Robinson described their classic technique for ACDF. The Smith-Robinson technique quickly became the standard of care for surgical treatment of cervical radiculopathy. Around this time in 1962, John Charnley implanted the first modern total hip. Maintenance of normal joint motion was in vogue. In 1966, Dr. Fernstrom described the use of stainless steel balls as an arthroplasty device to treat headaches in cervical radiculopathy. However, substantial complications did occur with the Fernstrom ball arthroplasty, including subsidence and implant migration. As a part of this talk, I was asked to describe some naysayers. There was at least one famous surgeon who did not have very nice things to say about the Fernstrom ball arthroplasty, but he hated spinal fusion just as much. And his contention with the Fernstrom ball arthroplasty was related to the perceived poor reproduction of native biomechanics. He designed his own implant, which featured a silicone ball. This had improved viscoelastic properties that allowed motion and also a cushioning effect. Unfortunately, his cadaveric studies found that this device disintegrated after 20,000 cycles of load and was not appropriate for human use. Interest in cervical arthroplasty reignited in the 1980s. Dr. Brian Cummings articulated the goals of an ideal arthroplasty device as one that leads to pain relief, has stability, has mobility, retains facet competence, has no adverse effects on the adjacent segments, and does not require iliac crest autograft. In 1991, the Bristol-Cummins device was introduced. It included a ball and socket articulation to allow motion, but had end plates to prevent subsidence. The device used anterior screws to create fixation. This further necessitated a large anterior flange. Of the 20 patients who had this device, at least 5 had screw loosening or breakage. While development of cervical arthroplasty proceeded, it was becoming more clear that despite great results, ACDF had issues, in particular, adjacent segment disease and pseudoarthrosis. In 1999, Dr. Hillebrand published a landmark paper showing the high rate of adjacent segment disease following ACDF. In the early 2000s, multiple companies began to enter the US market with IDE trials. Many of the pioneers in cervical disc arthroplasty are the other faculty in this course. Drs. Derman and Ziegler compiled a nice timeline of these trials. We'll be going through these in order of start of their trials. The Brine disc was the first device to enter US IDE trials in May of 2002. My mentor, Dr. Rick Sasso, performed the first Brine disc in the United States. The Brine had a porous titanium surface for ingrowth, which obviated the need for a large anterior flange and screw fixation. This reduced the anterior profile and may have improved dysphagia. The articulation was polyurethane on titanium. Around this time, the total joint surgeons recognized polyethylene wear debris as a cause of osteolysis. The Brine disc had outer polyurethane membrane to contain any wear particles. The choice of ingrowth fixation did require reaming the end plates with a circular milling device for insertion. The Brine was approved in 2009. After initial success, it was eventually taken off the market. Rumor was one of the component manufacturers went out of business, but sounds like Tony is going to bring it back. So that's great news. In the meantime, the Bristol-Cummins arthroplasty was redesigned into the Prestige ST. It entered US trials in 2002. Note the addition of a locking mechanism for the screws to avoid screw loosening and back out experienced with the previous generation. The articulation was also made less constrained than the original Cummins device. This acted to reduce stress transfer to the bone implant interface. Results were favorable, and it was approved in 2007. The ProDisc C was introduced in Europe and then brought to the United States starting in 2003 when trials started. It has a ball and socket articulation, cobalt chrome on ultra-high molecular weight polyethylene for the bearing surface, and an ingrown surface for fixation. These are elements that previously demonstrated success in total hip. While the Bryan disc used a semi-spherical reaming device for initial fixation, the ProDisc C used a keel. This allowed it to skip the cumbersome milling step and use the keel cutting step instead. Approval was obtained in 2007. In July of 2022, the next generations of the ProDisc, Vivo, Nova, and SK, were approved. In 2005, the PCM disc started trials and was ultimately approved in 2012. The device used a cobalt chrome on polyethylene bearing surface. This disc was different from the previously approved designs in that the teeth, small teeth, were used to achieve initial fixation. This may lead to less bone loss in case of future removal. Ultimately, it was removed from the market, reportedly for business reasons. In the meantime, the Prestige ST was redesigned again into the Prestige LP. Trials started in 2005. The stainless steel material was changed to titanium ceramic on titanium ceramic for the bearing surface. This had better wear properties and also prevented wear particles that contain nickel, cobalt, or chromium. The design went away from an anterior flange with screw fixation in favor of teeth and an ingrown surface. The Prestige LP did have small tabs anteriorly, but like the Bryan disc, this was used to guide depth of insertion. The titanium resulted in less metal artifact on MRI imaging. This disc was ultimately approved for 2-level use as well in 2016. The Secure C featured a selectively constrained cobalt chrome on poly bearing. It had a lower cylindrical articulation to allow unlimited axial rotation, like the rotating platform of distal femoral placement. This further reduced stress transfer to the bone implant interface. The upper spherical articulation allowed bending and translation in multiple planes. This device had a 0 and 60-degree lordosis options, and it was approved in 2012. There were some implants that entered IDE trials but never made it to market. The Kineflex C entered IDE trials in 2005. It featured a cobalt chrome on cobalt chrome articulation. The initial motivation for this type of bearing in total hip was that it had better wear characteristics and did not produce the polyethylene wear particles that caused osteolysis. However, early reports of cervical arthroplasty showed that osteolysis was not as prevalent in cervical arthroplasty compared to total hip. This may be due to the far smaller forces in the neck versus the hip. In 2010, DePuy recalled their ASR metal-on-metal hip system due to metal wear debris. This had led to some severe inflammatory reactions as well as high serum cobalt and chromium levels. In this context, the Kineflex C never made it to market. In 2018, Dr. Cork and members of the group in the initial IDE trial published their 5-year results. They report generally favorable clinical outcome measures. The mean serum cobalt level was 0.2 micrograms per liter, and mean serum chromium levels were 0.3 micrograms per liter. In surveillance for a metal-on-metal hip, the recommended level for removal of such a hip is often 10 times that amount, so 2 micrograms per liter as opposed to 0.2. Similarly, the Cervical started trials in 2005, but never made it to market. It was also a cobalt chrome on cobalt chrome bearing surface. The articulation was a double saddle shape to allow for motion in multiple planes. Achieving this type of articulation geometry is probably hard without using metal on both sides. This, unfortunately, was another casualty of the metal-on-metal recalls. The Surpass disc was a self-centering ceramic on ceramic device that entered trials in 2005. It also never made it to market. Unfortunately, I couldn't find the picture of it either. Even in total hip arthroplasty, The ceramic on ceramic bearing is rarely used because it can shatter. Another potential issue with ceramic on ceramic is that it can cause a squeaking noise with motion. And so imagine if every time you went like this or like that with your neck, you heard a squeaking noise reverberating through your neck. Combined with the fact that wear is not a major concern and the high cost of manufacturing ceramic implants relative to metal or plastic, it is likely the company decided not to pursue this further in favor of other designs they owned. Each group of surgeons and designers were attempting to more closely reproduce native cervical motion with different articulation designs. It was known that the center of rotation was not static, but instead translated with flexion extension. The Mobi C featured a cobalt chrome on poly bearing surface that allowed the poly to slide and self-adjust the instantaneous center of rotation during flexion extension. This device eventually was approved for single and two-level use in 2013 and was the first device to be approved for two-level use. The Discover disc entered trials in 2006. While preliminary results of the US IDE trials were promising, studies coming from Sweden and Norway showed a higher index level reoperation rate in the arthroplasty group and no significant benefits versus ACDF in terms of outcomes. This disc was never approved in the United States. Instead of metal end plates, the Neo disc used a polyester woven fiber jacket to contain a mobile silicone core. The silicone core would allow motion and cushion against any axial force, like the Nachemson silicone ball arthroplasty. However, silicone implants had gotten a bad rap in metacarpal phalangeal joint implants in the hand and also in breast implants. In these anatomic locations, they caused a severe inflammatory reaction. This device completed 2-year trials, but never made it to market. The M6C allows for axial compression by use of compressible polycarbonate urethane core with weaved polyethylene fibers. It had an outer polycarbonate urethane sheath to contain any wear particles. This disc was designed to cushion against axial compression forces to further reduce adjacent segment stresses. Some of the design elements resemble that of the Bryan disc. The M6 was approved for use in 2019. The simplified disc is the latest device to achieve FDA approval for single and two-level use. It features PEEK end plates with titanium coating for end plate fixation. The bearing surface is PEEK on ceramic. The most immediate benefit is less metal artifact on MRI than even titanium implants. This bearing surface does not have a commercialized predicate in the total knee and total hip space. This bearing surface performed well in vitro and in short-term and now midterm studies. Long-term studies are necessary to see if it holds up over time. As IDE trials came out with their data, several questions arose. ACDF had an excellent record. To improve upon that would be difficult. Furthermore, unlike in the hip or knee, where motion of the implant dramatically improves the function of the operating joint, a single level ACDF has little perceptible effect on the overall range of motion of the neck. The benefit for cervical arthroplasty is at the adjacent level as opposed to at the index level. Some early results showed no difference versus ACDF. If so, why do a more expensive arthroplasty when it may have yet unknown long-term complications? Other early results showed better neurological outcome. If neurological outcome is achieved by decompression, how is it that arthroplasty gets a better neurological outcome than ACDF? Are better decompressions being done? Maybe by routinely taking down the entire PLL or routinely decompressing both sides. Can you just use these decompression techniques in your ACDF instead? Initially, there was no long-term follow-up available. It was uncertain if any favorable results shown in the studies would persist over time. There was also a concern that financial conflicts of interest would confound studies results with the IDE trials. Finally, cervical arthroplasty device was more expensive than ACDF. From the payer's perspective, any potential cost benefits from reducing reoperation at an adjacent level would occur far in the future, while they paid a higher price for the implant today. Dr. Singh's group published a paper looking at industry relationships in lumbar disc replacement. They found that conflicted studies were significantly more likely to report favorable results than non-conflicted studies. They cautioned surgeons to interpret clinical results within this context. Dr. Tim Gurman from the UK wrote a letter to Spine when some of this data was coming out, and it echoed the sentiments of many spine surgeons. He felt that data was being accepted too hastily and too enthusiastically. He urged for detailed analysis of the data and long-term monitoring via registries. While caution is appropriate when evaluating new technologies, by 2012, longer-term data was starting to come out. Doctors Chapman and Rue wrote an editorial about whether or not arthroplasties should still be considered experimental. They conclude that implant-related complications seem to be rare. Intermediate-term results were favorable, and they consider arthroplasty a reasonable alternative for properly selected patients. For evaluation of long-term success, they used total hip arthroplasty as a benchmark. In 2017, the members of AO Spine International were surveyed about their perception of cervical arthroplasty. The vast majority still felt that ACDF is a standard of care. The most important reasons cited were perceived low evidence of benefits and high cost of arthroplasty. This year, we published our data on the 20-year follow-up of the initial Brain Disc IDE trial. We were able to obtain over 90% follow-up in a small group of patients that was randomized in a prospective fashion. The 20-year results in our arthroplasty cohort was 100%, and the 20-year survival rates in ACDF was 95.4%. Compare this with total hip arthroplasty, the so-called operation of the 20th century, which according to a large registry report has a 20-year survival of about 70%. Despite a higher reoperation rate in the ACDF group, there was no difference in mean outcome scores between ACDF and arthroplasty at 20 years. Currently, there are over 35 cervical disc arthroplasty devices being used outside the United States or in various stages of development. Over the last 60 years, surgeons designed implants within the context of available scientific data at the time. Differences in opinion, whether for or against arthroplasty or for or against specific designs, highlighted each surgeon's effort to do what's right for their patients. It's really exciting how much development there has been and how many devices are currently in development. Some of the designs are starting to converge, and I'm excited about that because it hints that we're getting closer to an optimized design. We now have 20-year results on cervical disc arthroplasty. The average age of an arthroplasty patient in the IDE trials was about 40. As we continue to innovate, we should aim for an ideal disc replacement implant to perform well for 40 to 50 years. Thank you so much for the opportunity to present. And I'm sitting here with the stars that went through this whole process firsthand. So love to hear any of your own personal experiences about the history.
Let me just first say thank you, Jason. Many greetings to Rick Sasso, and you did a fantastic job. And for anybody who wants to see an amazing talk, Jason has a beautiful juxtaposition of the results of the fusion versus Brain disc arthroplasties, 20-year perspective. And he put a fluid collage together of the images, and I thought this is really evocative. It just, without any numbers, shows what's very cool. One question I have is, and I know you're a newcomer and you can look back in the trials and tribulations of disc arthroplasty. One criticism aside from the conflict of interest always was that patients who want to have a disc arthroplasty are different than those during the trials. They're extremely motivated, they're extremely healthy patients. And for our very large healthcare system, which is 52 hospitals, one of their quality officers, when we looked at all spine surgeries, we had complication rates, and discectomies are one of the lower ones. But there was only one procedure type that had literally a 0% complication rate. That was cervical disc arthroplasty. And like lumbar disc arthroplasty was 0.05, something like that. It was ridiculously low. Again, testament to only few surgeons with very careful patient selection doing that. So my question is, talk about patient selections and patient motivations towards disc arthroplasty outcomes.
Sure. So in the IDE trials, hopefully the differences in patients and their motivation was accounted for by the randomization protocol. In real life, if you adhere by the strict inclusion criteria in these trials and you have a motivated patient, it can't hurt. And I think you would still get as good of a result.
Okay. Any other questions?
A couple things stood out in your talk that you presented as fact. And depending on what health system you're in, the arthroplasty is not more costly than the fusion. In our community, most surgeons are not using allograft and a first-generation plate. They're using some cool cage, some really cool biologic, and a plate. There's an unpredictability of the cost of a fusion construct. There really is no unpredictability. I mean, the cost of the artificial disc is an artificial disc. I think that's a difficult assumption to make that arthroplasty is always more expensive. It just kind of depends what you do. And then some of the re-op data, we focus on adjacent segment. Okay, that's fine. But what about index level? There is a finite incidence of non-union that requires reoperation. The reoperation index level for arthroplasty compared to fusion is vastly different, at least when we went back and looked at our place. Those are the two things that really stood out to me to at least balance the cause in both directions.
Absolutely agree with all your points. Yeah, so we all know the data about pseudoarthrosis and asymptomatic pseudoarthrosis requiring surgery. And it sounds like in all of your experience and all your registry data and the registry data presented by other people that the index level reoperations for cervical arthroplasty are quite low. And so, it definitely, there's something to be said about not having to go back at the index level. And regarding the cost, once the arthroplasties are more widely accepted, once you hit that scale, I imagine costs are going to have to come down if they're not already the same.
Yeah, Jason, it's Jack Sigler. As Scott said, that's usually not an issue. And in fact, one of the most impactful papers on health economics was really designed by Kim Norton, who's going to be speaking this afternoon, where she was able to get access to Blue Cross actual payer data. They were willing to sell that to people who wanted to research it. And at 4-year follow-up, their actual costs were 12% less for the patients who had gotten disc replacements than fusions. And that caused enough introspection, even in the big insurance industry, that it helped flip a lot of the regional Blue Cross carriers. So, I don't think cost is, and that didn't even include long-term reoperation rates, which, as we know in every study, always show multiples less in the CDR group at both index and adjacent levels. So if you put that in, it's even a bigger cost saving. The problem is that as we worked with insurance companies, they have a very short horizon. Their horizon's only about 18 months. That's their retention for their average customer, and they just feel they'll be moving on to another insurance company, not thinking about the fact that they're getting someone else's post-op patient. That sort of doesn't fit into to the equation in their C-suites. So thank you very much for the timeline, Jason. That was wonderful.
And this, I think, will conclude the morning session.